Thank you, Jordan, for that introduction. Like he said, we're really just going to be going over um, how gastric bypass surgery and pharmacogenomics can affect medication response. So I first wanted to give like a brief overview of the different types of bariatric surgery. I just included the three most common ones that most people know. The first is going to be gastric sleeve. This is going to be a restrictive procedure where about 75 to 85% of the stomach is going to be removed. As of recently, this is actually going to be the most common type of bariatric surgery in the US, and it has pretty modest results in terms of weight loss. So about 50 to 60% of excess weight is lost at 1 to 2 years after the procedure. And then gastric bypass surgery is going to be the one that we're really going to be focusing on for the majority of the presentation. And my next slide will kind of go into more depth on it. So I'll kind of hold off for now on that. But then the third type of bariatric surgery is going to be gastric band. This is also a restrictive procedure, but this is actually, it can be reversible. And so an adjustable band is placed just on top or around the proximal stomach and really just create a small pouch. It does have the lowest perioperative risk and it is associated with the least amount of weight loss. So typically about 15 to 25% within like that 1 to 2 years after after the procedure. It does have the highest rates among long-term complications and has like the highest frequency of needing reoperation. And so because of these factors, it's really not really used anymore. So in terms of gastric bypass surgery is also known as Roux-en-Y gastric bypass surgery. This combines a restrictive and malabsorption component. So as kind of seen on the picture on the right, a gastric pouch is going to be created and then it's going to be connected to the distal jejunum. So it's really going to bypass majority of the stomach, the duodenum, and then the proximal jejunum. And this is going to have the greatest results in terms of weight loss, about 60 to 80% weight loss at 1 to 2 years. But it also does have the highest risk for micronutrient deficiencies, dumping syndrome, and other surgical complications. And before, this used to be the most common type of gastric bypass surgery, but as of right now, it's that gastric sleeve. And so I did want to kind of go over how medication absorption can be affected by gastric bypass surgery and really talk about like the physiology portion. So with the procedure creating a small gastric pouch and the anastomosis, this is really going to restrict the volume and the surface area that allows for like drug dissolution and absorption. And this is also going to kind of promote that slowed gastric emptying as well. And then since we're bypassing that stomach, this is where a lot of the parietal cells are located. And we're actually going to see an increase in the stomach pH just because we're getting rid of a lot of the stomach. So now the ones that are located, we're going to have more of the parietal cells, I guess, in relation to the amount of the stomach that is left. And then so this could impair the drugs that are going to need an acidic environment to be absorbed. And then for bypassing the duodenum and then the proximal jejunum, this is going to decrease the surface area for drug absorption, and they also might not have adequate transit time for full absorption of the medication. And kind of this, we're thinking of the extended release formulations of medications. Additionally, some key transporters, metabolic enzymes, and efflux pumps are located in the parts that are actually being bypassed. And so this is going to reduce the body's ability to metabolize and absorb some specific medications. And then we have decreased contact with intestinal and with the proximal intestine. And so this can impair enterohepatic recycling and then also reduce the bioavailability of the medications that need to go undergo first pass metabolism. So it's kind of like in general, kind of the physiological I guess, changes that can happen with medication absorption. I also wanted to provide information on where a lot of these metabolizing enzymes, specifically the CYP enzymes, are located in the body. This is obviously not encompassing all of the metabolic enzymes, but I really just chose the ones that we see more commonly in outpatient pharmacy that are going to be that have the most impact on medications. And so, as you can see, most of the enzymes are going to be really located in the liver, the duodenum, and then the small intestine, with most of the enzymes located in the liver, which I think we kind of all expect that. For CYP1A2 and then CYP2B6, most of or majority of them, I probably say exclusively, are just located in the liver. And then with CYP2C9 and then CYP3A4, they do have significant amounts of their enzymes located outside of the liver. So looking at the duodenum and then small intestine. And so I was trying to look for kind of articles that investigated the metabolic activity, some of these CYP enzymes pre and post gastric bypass surgery. I didn't really see a lot of research being done. I really only found two articles. So the first one I found was done in 2019, and they were measuring five CYP enzymes metabolic activity, specifically CYP1A2, CYP2C9, 2C19, 2D6, and then 3A4 and 3A5. And so they included 11 patients. They took a cocktail of the five medications listed there, which are going to be the substrates of those enzymes. And they took the cocktail medications at each of their three visits. So right before the surgery, just to get like a baseline, they took it 5 to 8 weeks after the surgery, and then 25 to 30 weeks after the surgery too. And they uh, really found that for CYP3A4, CYP3A5, and CYP2C9, that the metabolic activities did increase slightly 5 to 8 weeks after the surgery, but then after that, they had returned to baseline. And then for CYP1A2, CYP2C19, and then CYP2D6, they really didn't find any significant long-term changes in the metabolic activity. And then they also biopsied the liver and the jejunum just to see kind of the frequency of the different CYP enzymes located in those specific body parts. And so they have found that CYP2C9 and CYP3A4, if you had higher levels of the enzyme in the liver, you were more likely to have higher um, liver, I guess, enzymes in the intestine for those two enzymes. Um, and so I think this is pretty consistent with kind of what the previous slide had said. Both of these enzymes are located in the liver as well as predominantly also in like the small intestines. And so their conclusion was that gastric bypass surgery really didn't lead to significant long-term changes in CYP activity at that 25 to 30 week mark. Um, and so that's something that I found interesting. This next article was actually looking up to 2 years after gastric bypass surgery. And so they had patients take a cocktail of medication, so the caffeine, losartan, omeprazole, which are really going to be correlating to CYP1A2, CYP2C9, CYP2C19. And they actually had two different arms. So they had patients that underwent gastric bypass surgery and then those that did more of a restrictive calorie treatment to help with weight loss. And so all of these patients took the cocktail medications. They took it like at baseline, 3 weeks after the treatment started, 9 weeks after, and then 2 years after the treatment. They were able to analyze 60 patients, and they had found that CYP1A2 at that week 9 mark, there really wasn't any change in metabolic activity, but at that year 2 mark, they did see slight increases in metabolic activity compared to week 9, but it really wasn't a significant increase in activity. For CYP2C9, they actually saw a decrease in the metabolic activity at that week 3 mark, but then after that, they really didn't find any changes to the metabolic activity. For CYP2C19, they did see metabolic activity increase at week 9. And then 2 years after the surgery, they also saw increased activity as well. Um, and so for something that was really interesting is they actually genotyped all of these patients for 1A2, 2C9, and 2C19. And they saw that the increased CYP2C9 activity was actually seen across all of the phenotypes when compared to like the baseline activities. And they actually saw significant changes in the rapid metabolizers and ultra rapid metabolizers for 2C19. And this kind of suggested that the star 17 allele or those carriers actually may be more susceptible to changes of 2C19 activity with kind of fluctuations in body weight. As for like the 2C19 poor metabolizers, they didn't see significant changes in the metabolic activity, but they still, in general, did see an increase in activity, I guess, pre and post surgery, but just wasn't as significant. And then this phenotype pattern, this was not observed for CYP1A2 or CYP2C9. It really was just for that 2C19. And so their conclusions was that CYP2C19 activity can increase after like weight loss and gastric bypass surgery, but for 1A2 and CYP2C9, it's really not going to be significantly impacted. Okay, so this is kind of like a summary of what I've found. I would say in general, um, I wouldn't say there's a lot of strong data or evidence behind kind of how Roux-en-Y gastric bypass surgery can affect metabolic activity, but I will say kind of like the strongest takeaway that I took out of it was that CYP1A2 and CYP2C9 activity is really not going to be significantly impacted by gastric bypass surgery. I think there's a potential for CYP2C19 activity to increase after the gastric bypass surgery, specifically or significantly with ultra rapid metabolizers and rapid metabolizers. Um, but still, only one of the articles kind of found this result. And then for CYP2D6, CYP3A4, and CYP3A5, only one of the studies actually looked at these enzymes, and they didn't find any significant effects in metabolic activity. So right now, I wouldn't say that they are significantly really impacted by Roux-en-Y gastric bypass surgery. So I guess kind of my takeaway in general is that there's not really, I guess, like concrete recommendations that we could maybe give to patients in terms of how gastric bypass surgery could affect pharmacogenomics and kind of the medications absorption and the response. But there may be something for CYP2C19. That's kind of like the didactic portion of the presentation. What questions do you have?